London, in 50 years' time. We've imagined a world where genetic science is a part of everyday life for families like this. For this generation, genes can be chopped and changed at will. Designer babies are the norm. And a cure for the last great killer disease of the Western world has arrived at last. Animal genes are manipulated to suit human needs and appetites.
Unhappy being bald? Losing out with the ladies? Have the Magi-Hair 3 gene implanted into your scalp now.
Am I gonna need that gene?
A genetic cure for baldness is some way off. But from the moment the secrets of our genome were discovered, scientists wondered if they could manipulate our genes. This big idea is gene therapy. For diseases caused by single gene defects, like cystic fibrosis, muscular dystrophy, or hemophilia, gene therapy seems like the ultimate promise. This man is living proof that gene therapy can work. He is the only person in the world to have been apparently cured of the devastating genetic disease hemophilia after taking part in a pioneering gene therapy trial. Diseases such as hemophilia are caused by malfunctioning genes. The idea behind gene therapy is simple. Why not insert a fully working gene into the DNA to do the job properly? Gene therapy uses a virus to insert the new gene into the nucleus, much as an envelope carries a letter. The gene randomly inserts itself into the genome. Now it can be read, and correct instructions passed out of the nucleus to the protein-making factories, which in turn produce the building blocks of our bodies. But gene therapy has its risks. Indeed, in some trials, it's proved fatal. In 1999, teenager Jesse Gelsinger died while undergoing experimental gene therapy for the liver complaint OTC. The virus being used to carry the replacement gene triggered a huge immune response that killed him.
My problem with gene therapy is not in the principle of it, but its execution. The young Jesse Gelsinger, this young man was not near death at all. He was leading a fairly healthy life. He died almost immediately from the actual therapy, so he died and he didn't need to.
Other mistakes have arisen from gene therapy. Children with immunodeficiency disease who are forced to live in a germ-free environment seemed like ideal candidates for the treatment. That was until two French boys developed leukemia when the randomly inserted gene designed to cure the condition disrupted a neighboring gene called LMO2. This caused blood cells to divide uncontrollably, resulting in the cancer. Some doctors believe the promise of gene therapy is so great that they're pressing ahead and trying to eliminate its risks. This is what they're doing in a joint trial between the Children's Hospital of Philadelphia and Stanford University for the single gene disorder hemophilia.
As the blood gets older, it'll get darker, but what's concerning me is that it's actually bigger than the other side, so it's not just a bruise on the skin.
2-year-old hemophiliac Dylan has a faulty gene passed on from his mother on the X chromosome. His body doesn't produce enough of the blood clotting agent factor IX, so he bleeds very easily. Today he's receiving an emergency dose of synthetic factor IX. The factor is expensive, between $50,000 and $100,000 per patient per year, so over half the sufferers in the world can't afford it. Patients can become immune to it, and it's painful to administer.
Jack, you know what? Actually,
Look, Dick.
I'm going to right here, but
I'm right here. Good boy.
Okay,
For 6 years, Dr. Katie Mano and Professor Kathy High have been working to design a safer virus to deliver a synthetic clotting gene.
Should we take it out now?
We'll take it out.
Please.
Hemophiliacs like Dylan only produce around 1% of normal clotting factor levels. Just a slight increase would make all the difference.
People who have slightly higher levels, say 3 to 4%, those people experience many fewer spontaneous bleeding episodes or dangerous bleeding episodes. So if we were able to maintain circulating levels in the range of a few percent and would allow him to basically be free of the fear of spontaneous bleeding episodes.
4 months ago, 31-year-old Chris Brent travelled from Australia to the US for the trial. He and his doctor had spent months persuading the Australian government to allow him to take part.
It's oftentimes quite difficult to know what a lot of these regulatory committees require, and so it takes a lot of time to fill out the paperwork, make certain that all of the right things have been done. There's no doubt that the tragic death of Jesse Gelsinger has changed not only clinical gene therapy trials, but in fact all clinical trials the world over.
I was aware that studies in America on gene therapy had been halted in 1999 after there'd been a death in a trial of someone who had OTC deficiency. There were some small concerns, but I was probably more interested in the big picture that could potentially benefit a lot of people.
The synthesized factor IX gene was injected directly into Chrissy's liver, a simple one-off procedure. Within 3 weeks of the trial, Chrissy's body began to produce its own factor IX, something he'd never experienced before. After 6 weeks, the new gene had pushed his factor level up to an amazing 12%.
I mean, when I found out that my body was producing its own factor IX, it was quite exciting. You know, I felt probably that I could push myself a bit further and wouldn't have to worry about any bleeds.
This is the goal that we had been working for more than 5 years, nearly 10 years. So it was a really wonderful moment. We have learned through the years not to get too excited until time goes by, but we were cautiously optimistic.
And Professor High was right to be cautious. After the initial improvement, Chrissy's factor IX levels began to drop back down. In addition, his liver had an immune reaction to the new gene, causing hepatitis.
I guess I was a bit disappointed that, you know, this factor that I had started to produce was now dropping, but other than that, I don't think it caused me any great anxiety. My liver's fine now, I believe. It certainly can cope with a few drinks, so that's all I ask of it.
Our poll asked people if they'd carry on with gene therapy if they knew patients had died from the treatment. Very few from the UK or America would continue.
I think it would depend on my circumstance. If it were, if I were terminally ill, if this was something that could kill me, I don't think there would be many choices left, and I would be for it.
If I was dying, I would probably still be willing to take a risk, but I suppose you would always have to weigh it against side effects and how long you were likely to have your life prolonged.
It's an unfortunate truth in medicine that many treatments which have become standard in their early days were tremendously dangerous. The classic one is of heart transplants, and the early heart transplants in the 60s had no chance of survival at all. And they wouldn't be allowed at all nowadays. But if they hadn't been done, we wouldn't have the standard technology of heart transplant. Now, gene therapy today is nothing like as risky as that. But it would be foolish to deny that there are real risks, some of which perhaps we don't know yet. However, if we don't take those risks, gene therapy will never go anywhere. So rather reluctantly, I think we do have to take them, even though it may cost, unfortunately, some human lives.
For Chris, gene therapy is a risk that appears to have paid off in an unforeseen way.
Well, since I had the gene therapy, which was 4.5 months ago, I've only had one bleed. So that's pretty extraordinary for me. I normally would have one bleed every 2 weeks, and it's actually been 3 months now since I've had a bleed. Can't entirely explain why, but it's been very good.
In Australia, there are strong hopes that Chris Brent's experience will allow more gene therapy trials to go ahead.
The consequence of this is very exciting and indeed is a major advance in gene therapy insofar as we're seeing the first glimpse of the possibility of a therapeutic benefit in a human being receiving gene therapy. In addition, he still seems to have been benefiting from the gene therapeutic procedure in a way that we don't fully understand.
Even with successes like Chris, some believe we're trying to run before we can walk. We just don't know enough about our genes to start experimenting with them to this extent.
We only have 30,000 or so genes, but there may be 200,000 or 300,000 proteins those genes code for. What the molecular biologist can't tell you is why does a gene decide to code for one protein versus another? So I think what we have yet to explore are what are those subtle factors out in the environment that may affect why genes become one protein versus another, and that's way down the line.
Replacement gene therapy involving the introduction of new genes will continue to carry risks until we know exactly how genes work.